I think we're already past time, so I'm going to get started with this session. Could someone close the door maybe? So thank you, those of you who have hung on for the late afternoon last day of the conference session. This session is about two related studies. The topic of both studies is the Maryland hospital payment reform. So I'm going to give you a little bit of background about the Maryland hospital payment reform and why we have these studies. I'll present the first paper, which is the main results of an NIMH-funded study. And then my colleague John Jackson will talk about the inverse probability weighting method that we used and describe a little bit more how to implement that or how we implemented it. And then Eileen Kennedy-Hendricks will give the third talk, which is on the Disparities Agency-funded study looking at the differential effects of the policy on racial minority groups. And then Jennifer Humensky will be our discussant. And so I'm just going to then proceed. Here we go. Okay, so this is the full study team. It's a collaboration across 4 universities, and so it's a pretty large group. And thanks especially to NIMH for funding one of the projects, and to NIMHD, the Minority Health and Health Disparities Institute, for funding the other, and that there's also a disclaimer about that the contents of this talk do not represent the official position of the Veterans Administration. Okay, so here's the map of my talk. And as I say, both presentations, or all the presentations, will be based on this payment reform in Maryland, which was instituted in 2014. In January of 2014, Maryland decided to change how it pays for all hospital services. All hospital services includes both inpatient and outpatient services, and essentially all of the hospitals in the state were enrolled under this new global budgets payment system, where all hospitals are prospectively assigned budgets at the beginning of the year, and they have to cover all needed services during the year on that budget. And again, it's both inpatient and outpatient. There are a few hospitals that are not participating, but they participate in a similar pilot program. So the main components of the reform are these prospective budgets, which are based on an estimated population, sort of client population for that hospital. The global budgets were implemented in part to gain better control over spending trends in Maryland, and so this policy was under an agreement with the Centers for Medicare and Medicaid Services, by which the state would agree to limit hospital spending in the state to a rate of growth of 3.57% per year. And the historical trend had been around 5.5% in the recent years. And so they're attempting to reduce spending growth in the entire hospital sector and better control spending, and then also implement various performance incentives to try to improve quality. So this reform, although it wasn't specific to psychiatry, our studies are about how this reform may have affected this, what I'm calling the psychiatric safety net, which is essentially the set of acute care services in general hospitals and in specialty psychiatric hospitals that provide sort of the network of care for people with acute psychiatric crises and chronic severe mental illnesses. And so basically what I'm talking about here are the inpatient, specialized inpatient units and psychiatric hospitals, plus all of their clinics and their sort of community networks. And so how would the reform in Maryland affect the psychiatric safety net? Well, immediately there was this cost pressure imposed on the system. There's pressure to either close down psychiatric units or shift patients from the more expensive locations to less expensive locations. There was also pressure to try to shift care from inpatient settings to outpatient settings, which are cheaper. And to also, there was a lot of interest in better managing psychiatric problems among patients who were being seen on medical units for medical problems. And so part of this effort was to try to better manage psychiatric symptoms in the acute inpatient setting, and it put a lot of demands on the psychiatry services in many of the hospitals. And then there was also this potential impact. These, again, are sort of things that may have driven changes that we then observe in our study. There was some uncertainty about how these fixed budgets would affect salaries for psychiatrists, because there's, on the one hand, much greater demand for psychiatric specialty care in hospitals, and on the other hand, there's sort of this fixed budget. So you can't hire away psychiatrists from other institutions outside the state. So in this particular study, we're trying to look at measures of how this safety net performed after versus before this reform went into effect, and we use a differences framework to try to assess those changes. And so in our case, we're looking at trends in Maryland before and after the reform went into effect in 2014 and comparing them to trends for the same outcomes in Virginia and Pennsylvania. And the idea of this is that in Virginia and Pennsylvania, we can find within the same sort of general region of the country similar sets of hospitals with similar demographic compositions in their service populations. And also, it's also part of a regional market for psychiatrists. And so the idea was that there would be a lot of similarities among hospitals in this same region. I will skip past this next part, but with the equation. But basically, if you don't know what a difference in differences analysis is, you're looking at differences in trends over time between a state that didn't experience a policy change and one that did. There's many different ways to look at those outcomes, and this is an example, but we're essentially going to be running a regression where we have a policy period state interaction that tells us about the effect of the reform. And this study uses Medicare claims data on a cohort of psychiatric inpatients. So we essentially took all psychiatric inpatients in these 3 states and gathered or organized Medicare claims data around their discharge from an index inpatient stay. So this is a cohort of discharged inpatients, and we're going to be looking at outcomes in the 30 days after they're discharged, including readmission. Okay, so the idea is to look at the effects of this reform in psychiatric care, but the results potentially have implications for other similar types of value-based payment reforms going on in other states. I think Maryland's been the most ambitious state in that all hospital services are covered under these global budgets, but there's lots of other experiments like this going on in other parts of the country on a smaller scale. Here we're looking at psychiatric readmission within 30 days of discharge, outpatient follow-up within 7 and 30 days, which is another quality measure that's standard, standard in use in looking at psychiatric quality of care. The length of stay of the index episode. It's sort of a general, again, quality indicator or access indicator. Those were our main outcomes, and then during the course of the study, we added some additional outcomes to try to look at what might be explaining our findings. So we looked at psychiatric emergency department admissions after discharge and observation stays in the emergency department, which are these very long, very lengthy emergency department stays that would often occur if there's not a bed available for someone in a timely fashion. And so that's another sort of indicator that the system may be overburdened. And then we looked at also transfers of patients from the index inpatient stay to some subacute care facility or to home care. So subacute care would include skilled nursing facilities and intermediate care facilities. And the reason why this was of interest is because care in those settings is cheaper than in an inpatient setting. It's usually around $300 or $400 a day versus $1,100 or $1,200 a day in an inpatient unit. And also, those costs were not borne under the hospital's global budget. The global budget covers hospital services, and these services are considered non-hospital long-term care. So there was a question as to whether hospitals would try to shift costs to providers who are outside of the global budgets. So we had hypotheses about that psychiatric readmissions would decrease, that outpatient mental health follow-up would increase, and the reason those two are connected is because initially when the reform was announced and in the initial months of it, there was a lot of talk about how we can reduce readmissions by improving follow-up and management of patients. So the idea that, or the hypothesis that these two effects go in the opposite directions is partly a test of that notion that you can increase quality and thereby reduce readmissions to the hospital. Length of stay could have gone up or down. On the one hand, maybe if you keep people longer in the inpatient unit, they're less likely to need readmission later. On the other hand, the shorter the length of stay, the more kind of the capacity of the hospital is freed up, and perhaps the costs are lower as long as readmissions don't increase too much. So this is the first that you have on the handout that I handed out. If you prefer to look at that, the reform was implemented in January of 2014, but it was really, that was when the whole thing sort of officially began. But the rollout of the policy continued for many months after that date. And so there were certain key things that happened. For example, although hospitals knew there were going to be global budgets eventually, in April of 2014, so 4 months after the policy began, the state announced, yes, all the global budgets have already begun, and you're all liable for those budgets as of the prior fiscal year. So it's sort of retroactively imposed on hospitals. And so we felt that the way to do this best would be to divide up the policy effects into 3 periods of time. So these are labeled at the bottom of this figure, period 0, period 1, and period 2. So essentially you have the first 6 months of the policy, and then the subsequent 12 months, and then the subsequent 12 months after that. So a 2.5-year policy effect period, and then that's being compared to a baseline 24-month period that preceded the policy. So again, these are Medicare data, claims data. Medicare were advantageous for us because the coverage is similar across these areas, and the claims generally capture the information that we needed in all 3 states. You can see that there were lots of exclusions. I won't dwell on this. These are kind of the common exclusions that one does in these kinds of studies using Medicare data. The largest exclusion was for discontinuous Medicare enrollment. So if somebody disenrolls, you obviously won't observe their service use in your claim. So that was the main exclusion. And then many people were transferred from the index stay to another acute inpatient setting. But we figured that we would pick up those observations from the destination inpatient stay and so we didn't count them. Essentially, we didn't want to use them twice. So I want to get to the results, and I know I'm short on time. So this is, again, you have these handed out, but or actually you don't, but you have the information that I used to produce this. But in any case, so follow-up appeared to improve slightly and then decreased in the final period. Inpatient readmission declined over time. So these are bar graphs for Maryland only. So just looking within Maryland over time, these are what the unadjusted averages looked like in the 4 periods. And the gold bars are follow-up within 30 days, and the red bars are inpatient readmissions. You can see a definite decrease in the readmission rate over time. This is length of stay, which didn't really change. Okay, so these are some of the other outcomes. The gold bars on the left are the transfers to a non-acute care institution or subacute care directly from the inpatient stay. Those increased over time within Maryland. Psych emergency department visits did not increase in prevalence, and observation stays really didn't increase much over time, or there wasn't a consistent trend really. Okay, this is looking at among those people who came to the emergency department, what was their likelihood within that 30-day follow-up period, what was their likelihood of being readmitted? And you can see clearly from the gold bars that if you had one of these psych emergency department visits, your probability of being readmitted to the psych unit was low. Or lower, I'm sorry, lower in the later periods than in the earlier periods. So that's suggesting that the hospital was actually administratively restricting admissions at point of entry into the inpatient unit. So I know I'm on red here. I started a little late, so I'm just going to quickly run through these. So these are the time trends over time. I just wanted to point out one thing, which is useful for anyone who's doing this kind of work, is you want the comparison groups to have the same time trend after the policy implementation as before. And you can see clearly, so this dotted line up here is Virginia. You can see in the policy period, which is to the right of the vertical red line, that there was definitely this change in Virginia here. You can see it here, and you can see it there. Those are, a change in trend that will tend to bias our difference in difference estimates of the effect of the policy, and in fact will tend to make it look larger. If I had more time, I'd tell you a little bit more about what may be going on there. And then these are our marginal effects results. I'm almost to the end. So these charts show that the policy resulted, for example, in a 3.2 percentage point reduction in the likelihood of follow-up in the 30 days after admission in period 2. So that third column gives you the marginal effects and their significance. Psychiatric readmissions were reduced by the policy. Length of stay did not change much. So these are from these difference in difference models. The discharges to non-acute care institutions increased. Psychiatric emergency department visits may have decreased slightly in the last period, and observation stays also decreased in the final period. So the story here is one of a general contraction in access to safety net care at Maryland hospitals. It does suggest that there was a savings, but the savings didn't seem to be due to some great, vast increase in quality in terms of connecting people to outpatient care, because outpatient care actually decreased as a result of the policy. So it wasn't as though we were better managing discharge and connecting people with services, and as a result they're not coming back to the hospital. It's just some alternative explanation like administrative controls on access to inpatient beds. And as I say, there may have been some cost shifting here to non-acute care institutions. We would expect also there was probably some cost shifting to community-based outpatient providers. We weren't able to observe that, unfortunately, or test that, because we don't have data on community providers. We only have the hospital services data. So that was our main limitation, and I'll just wrap up there. Thank you so much. So we should have the next one. I think at the end.
So good afternoon. My name is John Jackson, Assistant Professor, Department of Epidemiology and Mental Health, Johns Hopkins Bloomberg School of Public Health. Like Eric, I'd like to acknowledge the funding from NIMH and NIMH.D in making this work possible. Today I'm going to talk about the methods that we used in this study, namely using propensity scores to estimate the effects of payment reform via difference in difference models or comparative interrupted time series models. I'd like to thank my colleagues at Johns Hopkins University, University of Maryland, and also the University of Pittsburgh. So the big picture here is we wanted to estimate the effects of hospital payment reform on various quality of care metrics. Is an interesting setup because even though we have follow-up from these cases, each of our time series observations are a cross-section of potentially different psychiatric inpatients. And we're doing all of this in Medicare claims data. So the question is, how do we identify the effect of payment reform on these trends? And so to identify the change in trend that's due specifically to implementing payment reform in Maryland, we have to net out factors that affect trends. The first issue that we have to net out are secular events that coincide with the implementation of payment reform, and then also changes in case mix before and after payment reform is implemented. So the first issue, as Eric alluded to, we're using a design and a modeling approach that implicitly nets out effects of secular trends through the use of a control which relies on a parallel trends assumption. And the basic assumption is that the control group, which in this case I'm going to talk about Virginia just as an example, it provides a counterfactual trend for the treated group, in this case Maryland, had it not undergone payment reform. And so the difference between this counterfactual trend and the observed trend identifies the effect. Psychiatric inpatients in Maryland can differ from those in Virginia based on baseline covariates as long as we've measured all of the baseline covariates that affect trends. And so we're really assuming that there's no unmeasured confounding of trends between the groups. Now the parallel trends assumption can fail silently through changes in case mix. And so psychiatric inpatients before and after the payment reform may differ based on baseline covariates. And this can confound our comparison of counterfactual and observed trends. So if we see a change in a trend, is it due to the implementation of payment reform or is it due to the changes in case mix? And so to really isolate the change in trend that's due to the implementation of payment reform, we have used a propensity score weighting approach that reweights the pre and post payment reform, post payment reform inpatients in Virginia and Maryland so that they look like the inpatients precisely after payment reform was implemented in Maryland. And the weighting technique adjusts the case mix of each time series observation so that the measured characteristics are balanced with the observations in Maryland just after payment reform. And the key assumption here is similar in that we don't have any unmeasured covariates that affect selection over time and trends. And again, all of these key assumptions that we're relying here about no unmeasured confounding are untestable. So to give just like a big intuition about how these methods work, here's like a schematic here. And so the original data you can see on your left. So I've represented a set of time series observations in a particular group at a particular time as a rectangle. And so the top line of rectangles in blue represent time series observations in Maryland in each of the 4 study periods. And the ones on the bottom in orange represent the set of time series observations in Virginia, which is our control group. And I've colored them blue and orange to sort of signify the fact that they may have different distributions of baseline covariates. And then I've also, within each group, colored them differently. So you can see an increasing darkness in blue and also in orange to signify that we have different inpatients in each set of time series observations, and they may differ in terms of the distribution of their baseline characteristics. And so that's our observed data. Our first goal of reweighting is represented in the middle panel. So the first thing we want to do is we want to reweight the data so that at each time point the psychiatric inpatients in the control group look like the inpatients in the treated group. So those in Maryland are reweighted so that they have the same distribution of baseline characteristics as those in Maryland. And so this removes confounding by baseline covariates across Maryland and Virginia, but we still have these changes in case mix. And so the second goal of reweighting is within each group to reweight each time series observation so that it looks like the period just after payment reform is implemented, particularly in Maryland. And so the weighted data from Maryland provides a counterfactual of trends under payment reform in Maryland in the absence of changes in case mix. The weighted data from Virginia provides a counterfactual for Maryland under no payment reform in the absence of changes in case mix. So if you could follow that, that's pretty much the big idea of what we're doing here. So there's some underlying assumptions here. Among those with the same values of measured covariates, we assume that we have common support. So all inpatients have a positive probability of being in each time series group. So treatment versus control and also over time. And that may be violated if certain types of hospitals are only located in Maryland and not in Virginia. And those are included in our target sample. Another one that we've relied on that I've discussed is we're relying on unconfoundedness, that trends in the control group reflect trends in the treated group that they would have experienced under no payment reform. And basically, there's no unmeasured covariates that affect selection between treatment and control or selection over time. And we also assume that our measured covariates are not effects of payment reform, and also that the effects of payment reform in the treated group, those in Maryland, do not affect outcomes in the control group. And so now I'd like to talk more about the actual estimation via weighting. And so each observation in the time series is defined as an inpatient case I in a hospital J in a comparison group M and with a time of observation P. And so M just signifies whether observation is coming from Maryland, our treated group, or Virginia, our control group, and with 1 indexing Maryland. For time, which is represented by P, 1 is representing the period immediately after payment reform. And so each case has a vector of measured covariates at the patient level, X, and also at the hospital level, H. And with this notation, I can just describe that what we're doing is we have a weight, and the weight is a ratio of two conditional probabilities. On the numerator is the conditional probability of being in Maryland just after payment reform, given the hospital and patient level characteristics. The denominator is the conditional probability of being in a particular state and being observed at a particular time, given hospital and patient level characteristics. And so with understanding that our weights are the ratio of these two conditional probabilities, we can have some intuition for how they behave and how they adjust for differences in measured covariates at baseline. So essentially, if a case is observed in Maryland just after payment reform, then they have the same values for the numerator and for the denominator, and so they get a weight of 1, and so they are not weighted at all. So all the observations in Maryland just after payment reform do not receive a weight, with a weight of 1. Yeah. And those who are less likely to be observed in Maryland after payment reformed, the denominator is larger, so they get down-weighted. Those who are more likely to be observed in Maryland just after payment reformed, their numerator is larger, so they get up-weighted. And if the covariates are rarely observed in a particular group or period, some weights could be very large for particular observations. And if we have an extreme where some covariates are not observed at all in some group or period, the weights could go to infinity, in a case they would be undefined. And so we have these weights, and we need to know what these two conditional probabilities are. The problem is that we don't know what the true probabilities are, so we have to model them. And we could use a multinomial model if the number of groups and periods are small. Or alternatively, we can use a series of binary regressions with a common referent, in particular Maryland just after payment reform. And whichever approach we use the predicted values from these models to get estimates of the conditional probabilities. And then with those, we calculate the weights. And so if the weights will be correct if our models for the conditional probabilities are correct. In which case we'll equalize the distribution of measured covariates for each time a series set of observations, and such that they'll have the same distribution of measured covariates as those in Maryland just after payment reform. And we'll measure covariate balance in the same way that's done in the treatment effects literature, vis-a-vis propensity score matching, where we use a quantity known as the standardized mean difference. Essentially, we take the difference in means between two sets of time series observations and divide by their pooled standardized deviation. Essentially, we want them to be as small as possible, but at least we want the standardized mean difference to be below a quarter of a standard deviation. Generally, if we get the models right, we'll have a small standardized mean difference, and which means that we have balance, which means our weights are working. However, if our models are incorrect, we'll have an imbalance. And this can happen because of model misspecification. And two sources of model misspecification is one is misspecifying the form of the effect of continuous covariates on our outcome. And so we can rectify that by using more flexible specifications. The other is not allowing for heterogeneous effects of covariates on selection. So if we only include main effects in the model for the conditional probability, we're assuming sort of that the effects of a covariate on selection don't vary across levels of other covariates. And so we would want to rectify that by using covariate interaction terms. Another source of imbalance can occur because of lack of common support. And so what this can arise, as I said before, so some types of patients or hospitals in our target may not be represented in the control group at all. And so to rectify that, we would want to go back and redefine our target population and choose an appropriate subset of inpatients in hospitals from our control. Another issue that can happen is that we have hospital level covariates that are estimated from aggregate data, and one possible way to rectify that is if you have the source data to actually use that in the model as opposed to the hospital level data. So once we have these weights, we can fit a difference in difference model if we have 2 time periods, or if we're using 4 or more, we can use a comparative interrupted time series model. The big question is whether to include the covariates in the model. And if we have achieved balance in our weighting approach, we do not need to include the covariates in the model, although including the covariates in the model can be helpful in 2 cases. One is if our weights, if we still have residual imbalance in our weights. So we had some errors in estimating our weights, and so for some covariates, they still differ across sets of time series observations. And so in that case, we're going to estimate a conditional effect and possibly marginalize over it. And this is valid as long as we can correctly model the effect of that covariate on our outcome in our final model. Another reason why we want to condition on a covariate is to correctly model heterogeneity. And so, which is what we might want to do if we're studying the effects of payment reform on health disparities. And so just to walk you through what that might look like is I would argue that we want to go back to the drawing board first and realize that the effects of payment reform that we want is an effect within each disparity group, and the impact on disparities is the difference between those effects. And so we have to really repeat our entire algorithm for each disparity population. So carefully defining a target population, say, for whites and a target population, say, for blacks. Select appropriate hospitals and inpatients from controls for each disparity group. Conduct our propensity score weighting among each disparity group, and then check the balance. And what this process reveals is that there may be heterogeneous processes within each group that may be overlooked if we just do it en masse. And so from this perspective, the process for estimating disparities effects involves much more conceptual and analytic groundwork before we proceed to use so-called triple difference models. So just to recap, models for program evaluation often rely on a parallel trends assumption, and especially when we're using repeated cross-sections of hospital inpatient data, we can help satisfy the parallel trends assumption by adjusting for differences in case mix across group and also differences in case mix across time. And we do this by balancing covariates across time and group via propensity score weighting. And so I really like this framework because it helps us think really carefully about our target population. And through our covariate balance checks, we can monitor and improve the performance of propensity score weighting and how well it removes bias. Thank you.
Okay, hi everyone. I'd like to echo Eric and John in thanking those of you who have stuck around for this final session. So this study is an extension of the work that Eric and John have both described, but focuses on the implications of Maryland's hospital payment reform for racial disparities in care following psychiatric hospitalization. This is the same research team, so I won't spend time here, and it's the same source of funding as well, for which we're very grateful. So there are significant racial disparities in access to mental health care and the type of settings in which people receive care. Prior research has found that Black patients are significantly less likely to have follow-up care after a psychiatric hospitalization compared to white patients. Work done by my colleague Eric and some of his collaborators has found evidence that these disparities exist in Maryland specifically as well. And there are racial disparities in the types of settings in which individuals receive mental health care, with Black patients appearing more likely to have mental health-related ED and inpatient visits compared to white patients. ED use may reflect insufficient access to outpatient services, including specialty mental health care, or illness that has sort of advanced to a more severe condition. So we are interested in understanding what the implications of the payment reform are for racial disparities. It's unknown whether the reform and similar efforts to promote value-based payment models will exacerbate or mitigate racial disparities in mental health treatment. Theoretically, in an effort to improve care coordination and reduce the likelihood of readmission, hospitals may improve their systems and processes for linking patients to follow-up care. And these efforts could reduce racial disparities in outpatient follow-up by tackling one of the big discontinuities in care in which we see significant disparities. Hospitals might opt to increase investment in their outpatient psychiatric services, in part to try to reduce readmissions and shift service use to a lower cost setting. On the other hand, in an effort to avoid adverse selection, hospitals might reduce the psychiatric services they offer, since this is a patient population that tends to be more expensive. Safety net and non-safety net hospitals could also respond to the reform in different ways, and that has important implications for disparities in mental health care, given the different composition of patients that these hospitals serve. Safety net hospitals also could face greater challenges staying within their global budget, given that they're serving this higher need population. They could end up with a greater volume of psychiatric admissions if the non-safety net hospitals, for instance, reduce the psychiatric services they're providing. So the implications of the reform for disparities really depends on how hospitals are deciding to prioritize or deprioritize certain lines of services in inpatient and outpatient settings. So we are interested in understanding what impact the hospital payment reform had on Black-white racial disparities in outpatient follow-up care after psychiatric inpatient stay. We focus on Black and white disparities only just because the prior literature on these disparities, it's more robust than literature on some other disparities. And we're also interested in how the reform affects disparities in ED visits and hospital readmissions, and whether or not potential changes in disparities in response to the hospital payment reform may look different at safety net or non-safety net hospitals. So I won't spend a ton of time on the methods because it builds off of the same study design that Eric already presented and John provided sort of more in-depth explanation on, but we do make some methodological adaptations in this study that have to do with the sample that we include, the weighting strategy, and the models, which are now triple difference models. And so this means that we're comparing the difference in difference estimates for the Black subgroup to the difference in different estimate for the white subgroup and looking at whether or not those estimates are significantly different. Okay, so much of this is the same, but we do have some additional exclusions. One additional exclusion is that we limit our sample to discharges for individuals who are reported as Black or white. So that results in a little over 6,000 exclusions. In addition, we exclude patients from rural areas, which results in nearly 6,000 additional exclusions. And this is because the geographic distribution of groups in the states look a little different. And so getting balance within racial subgroups in rural areas in Maryland and our comparison states was just not possible. And so we wanted to have kind of the strongest internal validity by comparing more comparable populations. So, okay, so the covariates we list here are included both in the weighting algorithms, and we also adjust for them in our main models. John described sort of some of the reasons why you might do so. Hospitals in the top quartile of hospitals in terms of the percent of patients that they serve who are Medicaid enrollees. This is how we defined safety net hospitals. We didn't have a measure of the proportion of people who are uninsured, and so it was just based on sort of the proportion who are enrolled in Medicaid. So we adapted our weighting approach for this study because rather than only seeking to achieve balance between Maryland and our comparison states, or comparison group of hospital discharges and observable characteristics, we also wanted to achieve balance within racial subgroup. And so first we used the weights that we already had generated for the main analysis and looked at whether there was balance with these existing weights. And we discovered that there were several variables on which there wasn't balance within these subgroups. And so what we did was we interacted those variables with race in our propensity score models. And once we kind of did some iterative work on these weighting algorithms, we were able to achieve balance on most covariates within these two groups. And so this is the black subgroup, and on the left you see the standardized mean difference, which is one measure we use to assess balance across our covariates, and you see some outlier dots, which indicates that we weren't achieving balance in some of our groups. But then on the right, you see the standardized mean difference after weighting, and you see that all of the covariates for the different groups are within 0.25, which is our threshold. However, for the white subgroup, we were not able to achieve balance on this hospital safety net status variable, and we tried a number of different approaches using the original sort of fraction of Medicaid patients at the hospital, but this was a variable for the white subgroup that we were unable to achieve balance. And we do run stratified models by hospital safety net status. So all of our model or outcomes were binary. So these are logistic regression models adjusting for the covariates that I already displayed. We did estimate models that allowed us to estimate the effects of the reform in each of the post-policy periods, which is how Eric presented his results. Just for the sake of time, and given that sort of the story is somewhat similar, I'm just going to present results for models that are simpler pre-post and averaging the effects over the entire post-policy period. And the bottom table displays the sample sizes for the models in which we stratify for hospital safety net status. So one bizarre thing that we discovered when looking at these data was that we didn't see the racial disparities that we anticipated during the pre-period in Maryland. And this is inconsistent with prior literature, not only more broadly, but also within Maryland specifically. And so when we're talking about whether or not the reform reduced or exacerbated disparities, we're thinking about sort of a baseline point from which those changes might occur. And so just keep that in mind, I guess, as we're talking, because we don't see really obvious racial disparities. And for outpatient follow-up visits, for instance, they're certainly not the difference isn't in the direction that we expect. And for our comparison states, we also don't see large differences in these unadjusted averages during the pre-period. So this table displays the first set of results from the models we ran. And so we find that the hospital payment reform is associated with a significant reduction in outpatient follow-up visits of any kind, so not mental health specifically, for Black patients, and small reductions in mental health-related outpatient follow-up visits for both Black and white patients. And those are those diff and diff estimates in the third and fifth columns. When comparing differences between these groups, we find a significantly greater decline of 4.7 percentage points in the probability of having an outpatient visit within 30 days of discharge among Black patients compared to white patients that, according to these models, is attributable to the hospital payment reform. And this suggests that the reform contributed to a worsened racial disparity in outpatient follow-up visits for individuals experiencing psychiatric hospitalizations, although again, keeping in mind that we didn't really see an obvious disparity during the pre-period. When estimating differences by race and the effects of the hospital payment reform on ED visits and readmissions. We find significant reductions in ED visits within 30 days of discharge and readmissions for any reason, and for the psychiatric readmissions that are attributable to the reform among Black patients. We find no significant effects on these outcomes on white patients. And in estimating differences in changes in outcomes attributable to the reform, we find that the reform is associated with a significantly greater decline in ED visits among Black patients relative to white patients. So these next two slides present results of the models stratified by hospital safety net status. So these are the results for discharges from safety net hospitals, and we see here that at safety net hospitals, the reform appears to be associated with significantly greater negative effects on both all-cause and mental health specific outpatient visits within 30 days following discharge for Black patients compared to white patients. But we do not see any significant differences in the effect of the hospital payment reform at the non-safety net hospitals. So we've already talked a little bit about some of the limitations. We're relying on hospital facility claims only, and so there could potentially be a shift to outpatient follow-up care in non-hospital facilities that we're not detecting in these data. There are always questions in these sorts of studies about the appropriateness of the comparison group, but we did employ some techniques to try to address differences. And there's a potential for spillover across states, although other research on the hospital payment reform suggests this isn't occurring. So in summary, we find that pre-policy racial disparities were small in magnitude, and for some measures were not in the direction that we expected given prior literature. Our analyses suggest that the reform was associated with reduced probability of outpatient follow-up care, ED visits, and readmissions among Black patients, and that there were significant differences by race in the effects of the reform on outpatient follow-up and ED visits. In stratified models, we find significant differences in the effects of the reform on follow-up care only at the safety net hospitals. So key takeaways are no evidence that the reform has reduced potential racial disparities in these measures that we examined. And there's some evidence that it may have worsened mental health follow-up care for Black patients, particularly at safety net hospitals. Thanks.
Let's see, so they're gonna have some slides that are gonna come up.
Next set of slides.
Okay, I'll just go one. Okay. I want to thank Eric and the panel for having me here today. This is reading more about the policy. As you can see, I'm going to focus a little bit more on the policy landscape of this. I think this is really, it's a fascinating policy landscape in Maryland, and then the impacts of this reform. And we'll just have a couple questions that you may want to answer, or also see what the audience has. But I want to acknowledge my funding from NIMH K01 and no disclosures to report. And so first I wanted to just sort of put some context around the landscape in Maryland, which I've come across in doing analyses of costs comparing in New York and Maryland. It's a unique system there, which is essentially basically since the 1970s, Maryland has operated the country's only all-payer rate-setting system for hospital services. And so an independent commission sets the rate structure for each hospital, and all payers, private insurance, Medicaid, Medicare, pay for services according to these rates. And all along, the previous evaluations have found the system to be successful in containing costs. But in recent years, changing incentives with the changing healthcare system, along with Medicaid waivers and delivery system, have created pressures to increase the volume of services provided. So for Medicare, they're paying higher rates for inpatient services in Maryland than elsewhere in the country, and then the rates of inpatient services were going up. So it resulted in the Medicare is paying higher rates for Maryland than in the rest of the country. So in 2014, I apologize for the busyness of that slide, but I wanted to get the facts sort of straight and in there. But in 2014, CMS, which operates the Medicare and Medicaid programs, and the state of Maryland launched the all-payer model in which CMS and Maryland agreed that the payers, including Medicare, would pay the same rates for inpatient and outpatient hospital services. It meant that CMS would pay higher rates for inpatient care in Maryland than in other states. But as part of that agreement, Maryland moved hospital reimbursement from fee-for-service to a global budget. And in a global budget, all payers in aggregate pay hospitals a fixed amount for inpatient and outpatient services, adjusted for quality, but irrespective of hospital utilization. And so it was expected that providing fixed, predictable revenue allowed hospitals to focus on value rather than on volume, and reward them for investing in population health improvement. That was the goal. Some of the earlier evaluation results, there's a great deal of interest in the outcomes of this study, and Patel, the early evaluations found that within 6 months of implementation, January to July of 2014, 90% of inpatient costs were moved to the global budgets. So it was implemented almost immediately. And the per capita hospital cost growth was lower than was expected. It was expected to decrease costs by about 1%, and it decreased costs by about 3%. So the goal of the papers here today, and the study here today, was to look at the impact of the reform on psychiatric hospital costs and utilization. And so starting with Eric's paper, he examined the impact on hospital and inpatient readmissions and cost shifting to outpatient services, ED visits, and subacute non-hospital settings, comparing to comparison states of Virginia and Pennsylvania. And the model was a difference in difference model, which compares the changes pre and post reform in Maryland, which has the reform, to pre and post in the comparison states, Virginia and Pennsylvania, adjusting for patient and hospital characteristics that would impact the outcomes. He found there's a decrease in hospital readmissions, but no consistent change in outpatient utilization, emergency visits, or inpatient length of stay. However, discharges to non-acute institutions increased. And as he mentioned in his talk, it's not clear that whether the change to the shift to non-acute settings was completely the result of this policy reform, that there's some other things going on that might have influenced that. And he also mentioned that there's no data available on what happens to people once they get into the non-acute settings, because the data is only on hospitals. But I think as a sort of a policy question, it would be fascinating to know, what is the length of stay for someone who gets discharged to a non-acute setting? And then in terms of overall cost and quality, for example, what is the net cost or benefit of getting discharged to a rehab facility, staying there 2 weeks, versus getting discharged to home but needing to go back for a readmission for 2 days? What's the difference in costs? What's the difference in quality of care, quality of life? It's going to vary tremendously, depending on the circumstances. So it's an interesting policy question in terms of what are the unintended consequences, and are they good or bad? Moving over to Elena's talk, she found that, looking at racial disparities, she found that given that it's well known in the literature that there are existing disparities in outpatient follow-up care after a psychiatric inpatient stay, but it was unknown whether this reform would exacerbate or mitigate these disparities. And theoretically, the goal of this healthcare reform, in addition to containing costs, was to improve quality of care. And so it's possible that the hospital may improve efforts to link patients to outpatient care, which could reduce hospital readmissions, but could also reduce disparities in outpatient follow-up. So as she discussed her difference in difference design, comparing pre-post in states with and without reform, blacks and whites, and used inverse probability weighting to adjust for differences in client and hospital characteristics. And she found that reform was associated with reduced probability of outpatient follow-up care, ED visits and readmissions, especially for blacks and especially in safety net hospitals. And one question is just sort of why, which is always hard to tell from administrative data, and how would this change sort of as experience with implementation grows? I don't know if you were able to look at any finer cut points in the data to see, was it different like when the program first started early in implementation versus as time has gone on? Have any implications of those spillover effects, have they then changed the hospital's behavior as time has gone on? I don't know. It'd be something that in the future to look at. And finally, John's presentation, where he focused on the methodology of the inverse probability weighting, and the idea is that you have this, you have the group that experienced the intervention in Maryland, and you have these two comparison groups in Pennsylvania and Virginia that didn't. And obviously the gold standard of studies like this is a randomized control trial, but in the real world, the data doesn't exist to allow you to do that, and there's no way to do it in a practical way or a ethical way. And so sometimes we are in a position of having to compare to a comparison sample that's not randomized, and that and so there could be existing differences, underlying unobserved differences between the two groups, and so they've done a lot of work to cancel out or to wash out any possible unobserved differences between the intervention and control groups. And so they sort of looked at two things, one being the differences between the states, the differences in the comparison and control groups, but also looked at differences in case mix before and after payment reform was implemented. And the question I would really have is how much to what extent did you see the difference in case mix? I think you've got a paper right in there. Just to what extent did you see differences in case mix? How over time? To take a very dystopian view, what if the hospitals, instead of admitting a very sick person, they just stabilize them and then release them? Then maybe they're seeing a population that's healthier, and that helps contain their costs. Hopefully that's not happening. That's quite the unexpected spillover, unexpected effect, but just, what impact has this had on case mix? And so it'd be really interesting to see how much is accounted for by that, and how much is getting, if anything, is getting washed out by controlling for that. So I'd love to see that paper. But sort of just a final sort of question for the panel is, obviously Maryland has this very unique policy landscape where they've had this experience with the sort of the preset rates, that's experience going back 40 years. So it was a sort of a policy landscape that was amenable to implementing something like a global budget. But states all over the country are trying to minimize Medicaid costs, Medicaid redesign. New York's doing a lot, North Carolina. There's a lot of states that are sort of within their own policy and political and healthcare structures trying to find ways to mitigate costs. So do you think that some of the reforms that are that you're doing in Maryland, do you think that some of them are translatable to other policy environments, or is it something that's the Maryland's sort of uniquely situated to do? Those are really sort of the questions I have if you wanted to tackle any of those, or if the audience has any.
Well, one thing that I didn't tell you in my talk is that the big mistake that the state made when they did this reform was it only encompasses hospitals, it doesn't encompass providers. And so the providers' incentives are not aligned with those of the hospital.
Sure.
Thanks. No problem. Is that on? Yeah, so the state's reform of the budgets included hospital budgets, not professional care budgets. And so the providers were not within the budget system and didn't have the same incentives as the hospital did. And so the hospitals immediately went around trying to create these managed care provider networks where they could bring the providers under the reform budget and give them incentives to perform. And that's what's happening now in the state, is they've changed the reform again for a second wave to try to align those incentives. And I think that probably explains why we tended to see, you know, not much effect on quality and more effects just on spending. So I don't know, there's a general response to one of your comments.
Well, in terms of the, and Elena, you may know more than I do, but in terms of like basic demographics, because we didn't have a lot of symptom measures, most of the differences we saw were across state, I believe. Is that right? Yeah. So we didn't see huge shifts in case mix, but that's not saying that, you know, there were unmeasured differences that weren't detectable. But it's still, that's a very interesting question to parse out the effect on shifting in the types of patients.
And that's great, though, that if it sounds like there weren't big changes in the case mix, and it sounds like the hospitals weren't, you know, possibly aren't doing the dystopian, you know, which is great.
Marcella Horowitz-Lennon from RAND Corporation. Excellent presentation. Sorry, I got here a bit too late to hear most of it. But question for Arlene. In terms of the racial disparity, the black and white, the widening of the disparity in terms of outpatient follow-up, what comes to mind is whether there's a difference among racial groups in terms of where they get their care, both for hospital care and outpatient care, and whether you could model the, you know, the effects at the hospital or system level so that you can capture some of those differences where they are getting their care.
Yeah, that's a great suggestion. And I mean, I guess in a very kind of crude way, we're looking at that with the stratified models, just, you know, this basic safety net, but getting sort of more fine-grained is a great idea and a great suggestion. And, you know, I think there's some more work to be done on our end to just kind of look at those differences in settings, the discharges, where they're coming from, and whether there are some patterns there that might be informative in trying to understand the results we're seeing. Thanks.
One question. Did you figure out what happened in Virginia?
Yeah.
Why did the trend change?
So we looked, you know, or I looked on Google to try to figure out why there was an increase in psych emergency department visits in Virginia during our reform period. There shouldn't have been these major policy changes, but what happened was in Virginia, this is the only thing I could find, was that Cray Deeds, who's a state legislator there, his son stabbed him and then died by suicide. And that happened just before our policy reform occurred. And then in Virginia, there was, as a response to this, you know, crisis, they passed a bunch of legislation on basically saying that if anyone shows up at the emergency department, you can't let them go until you find them a bed if they need a bed. And there were all sorts of changes to the emergency petition rules whereby police could bring people to the emergency department. They'd have to, you know, stabilize them. And so I think that there was this event that then changed the trend in Virginia. And I'm still trying to figure out, I've run the models with and without those data points, and we get a weaker effect of the policy reform, but still a significant one on our outcomes. But you know, it's just one of those hazards of doing this type of difference in difference time trend work. Yeah, thank you again. So nice. Yeah, thanks for setting it up.